So my talk today is about right atrium and right ventricular functions before and after pulmonary valve implantation in the tetralogy flow. I have no disclosure. So repairing the tetralogy flow was causing several problems. The right ventricle outward tract stenosis causing the pressure overload to the right ventricles, and on pulmonary regurgitation, the tricuspid regurgitation is causing volume overloading to the right ventricles. So together with the volume overload and the right pressure load, and also myocardial fibrosis causing for the RV dysfunctions. RV dysfunctions are introduced to RV dysfunctions in drastic properties to dilate in the RBC. So this is a typical case for the post-repair tetralogy flow with a severe PR. So marked RV dilatation and also reduction of the RV contractions. Also, compression of RV interventricular septum toward to the left ventricle to reduce the size of the left ventricle to the impairment of the LV functions. So this is for the current indication for PV catheter intervention for after the repairing for the tetralogy flow. Any patient with symptoms for heart failure requiring pharmacological therapy and pressure overload status and RVP exceeded 70% of left ventricular pressure. Volume overload in RV DVI is more than 160, and RV ESVI is more than 80, and RV EDV over in LV EDP ratio is more than 2, and RV contraction is ejection fraction less than 40 to 45%. And also the electrical duration of the QRS duration is more than 180 milliseconds. Before we talk about changing before and after the transcutaneous pulmonary venous replacement, we must understand the basic anatomy and the function of the right ventricles. So the right ventricle has two layers. The outside epicardial layer, about 25% thickness, is a circumferential fiber orientations. The inside, 75% thickness of the endocardial layer is a longitudinal fibers orientations. Right panel shows if you open up the window from the outside of the right ventricles, you may see a longitudinal orientation of the fibers. So contraction was occurred along the fiber orientations. The outside is a circumferential contractions, shortening, and also inside it's an endocardial layer is a longitudinal contractions along the longitudinal fiber orientations from the tricuspid valve to the apex, and also perithysis-like motions from the RV inflow through apex to the RV outflow. Summarize of the basic characteristic of the RV contractile mode is important in contractile mode is shortening of the longitudinal axis with traction of the tricuspid valve annulus toward to the apex. And peristalsis movement from the RV inflow to the RV outflow, the time difference of the starting of the contraction in inflow to the outflow is about 20 to 50 milliseconds as a normal setting. And inward in the movement of the RV free wall, this is called a Bellows effect. And also bulging of the interventricular septum into the RV during LV contraction, and also stretching of the free wall over the septum from distal until posterior directions. And RV doesn't have any torsion or twist like LV contractions. This is for the two-dimensional echo demonstrating the characteristic of the RV contractions. The left panel shows the longitudinal shortening. So the middle panel shows the transverse shortening and a bulging of the IVS during LV contractions, a stretching of the free wall over the septum. The right panel shows the Bellows motions between the LV free wall to the interventricular septum. So longitudinal shortening is contribute to the 80% of the right ventricular stroke volumes, and rest of the whole motion was contribute to the 20 to 30% of the right ventricular stroke volumes. This can be demonstrated by the 3D echo as well. Left panel shows in separate from the different aspect of the contractions. We may see the longitudinal in peristalsis and Bellows effect. Right panel shows this is activation imaging. So you may see in a peristalsis movement from of RV from the inflow to the outflow. RV has three components, which is an inlet, apical, outlet. So we may measure for those three segmental volume changes and contractions and separately. Middle panel shows apical section inlet section is contribute to the most of the RV in stroke volumes. Apical section has a 45%, in the inlet section was a 36%. Outflow part of only about less than 20%. The right panel shows regional and global volume changes of RV along the cardiac cycle. This is the summary for the anatomy and the function, and also these functions of the right ventricles, the healthy and the disease status. So pressure overload right ventricle has demonstrated in dilation of the RV and also thickness of the RV wall, and also in a marked increase in fibrosis. And also the pressure overload has dilated the right ventricle, but mild stenosis, and also diastolic septal flattening compared to the systolic septal flattening in pressure overload. The cardiomyopathic right ventricle, such as arrhythmogenic right ventricle cardiomyopathy, has marked fibrosis with fiber flat replacement. From the physiological point of view, I think that we can use for the CMR and the longitudinal strain as the pressure volume route. The pressure overload was in a systolic septal flattening, and also longitudinal strain has reduced, and also desynchronous patterns with post-systolic shortening. The volume overloading has more retained for synchronous motion, and also the PV loop is a pressure overload high enough increase to the systolic and diastolic, and also ventricular pressure, ventricular arterial coupling. And volume in overload has been retained for the systolic and diastolic properties compared to pressure overload. This is the pressure volume loop of the right ventricles in a normal one, and this is so if you have a pressure overload, and then volume overload. Right ventricle has also poorly tolerated the pressure overload. So from the left side, if you increase in pulmonary artery pressure, it's easy to decline for the right ventricle in stroke volumes compared to the left ventricles. The right panel shows the global longitudinal strain of right ventricles before and after the PA banding. After PA banding, same ventricles, but I think it's a reduced in a strain rate. This shows the progression of the RV functions. Sorry about this one. Function for in the cases of the pulmonary artery pressure hypertensions. I think that if pulmonary artery pressure rise, then immediate early stage of this pulmonary artery pressure rise, the right ventricular ejection fraction was decreased. And final end, if the endodiastolic volume was increased, is farther down for the right ventricular ejection fractions. Right atrium, right ventricle functions before PVR. These are the parameters for the all assessment with IVC RV functions and RV systolic and diastolic functions, and also an RV PA coupling. including for the LA functions. This is in the clinical practice basis for assessment for the right ventricular functional assessment by echo. So RV wall thickness into IVC in a diameter with or without respiratory changes, and RV fractional area changes, and also like an ventricular interdependent septal shift with tissue Doppler to the systolic S prime velocity and longitudinal strain of the RV free wall. And of course, in a 3D echo demonstrated ejection fractions more precisely than the 2D in echo. This can be done by the MRI too. This is a feature tracking of the right ventricles by the MRI. So this method can make more assessment like global longitudinal strain as well as volume changes. This slide shows the echocardiographic assessment of the right atrial functions. Upper panel shows a right atrial strain, and lower panel shows 3D RA volume changes. So RA in our functions consists of the three components: the reservoir strain, in a conduit strain, in a contractile strain. And also the volume per se is a total emptying and passive emptying and active emptying. In follow-up patient, demonstrated significant reduction of the reservoir strain and also in a contractile strain. And volume per se is an early peak and a late peak in the emptying rate is lower than the normal in patients. This is a quad imaging of the ventricles and it can demonstrate the interchamber interactions between all four chambers. At the same time. So this is volume changes, area strains. We may see how each chambers interact with each other during the cardiac cycle. This is a summary of the impairment of the RV and LV mechanics in tetralogy flow in RV and LV and interaction of the RV and LV mechanics. All those parameters demonstrated the global, regional, strain, and also strain rate. And for the RV is global, and also the free wall is reduced. MRI may demonstrated the myocardial fibrosis by the LGE and T1 mapping. Volume loading, the effect of the volume loading on the RV ejection fraction and fraction area changes before the PVR. Vertical axis as ejection fractions and also fractional area changes. Transverse axis is RV endodiastolic volume before the PVR. So larger the RV endodiastolic volumes introduced for the lower the ejection fractions and fraction area changes. This is for using for the 3D echo, we can measure for the distance changes between tricus valve to the apex, and as well as distance between pulmonary valve to the apex. So compared to the normal heart, the tetralogy follow patient has markedly reduced to change of those two distances during the cardiac cycle. This is for the three-part analysis of the right ventricular volume in a setting. So I think that so red one is the tetralogy flow, as blue ones are normal, and yellow ones are VSD patient. So you may see in a tetralogy flow patient has a markedly reduced inlet and apical volume change in volume contractions compared to a normal heart in a VSD heart. So current indication for pulmonary valve catheter interventions. I think the volume overload, as I said before, I think the volume in RV-EDVI and RV-SVI, RV-EDV over and RV-EDV the same as in the surgical indications. what happened to like an RA and RB functions after the PVR? So summarize of these parameters to assess performance. I think that for RV, once after like a TPPVI has reduced RV volumes and reverse remodeling of the RV geometry with improved RV functions and increased the stroke volumes. LV can be improved on the functions in ejection fractions and torsions, and an increase in LV volumes, endodynamic volumes, as well as endosystem volumes. And for excitation, I think your duration was shortened. This is the RV volume in it's a meta-analysis of the data for like pre-PVR volume indexes to affect how much change of the both volume indexes. So vertical axis is changing ratio, and horizontal axis is pre-PVR index in RV-EDB or pre-RV ESP. This is all the same. I think the larger the volume of the RV may reduce in changing of post in RV in EDB changes. So some larger sample was a number of the cases for each studies. This is the prognosis value of like normalizing RV volumes after the PVR by the MRI study. So the cutoff value as RV EDVI is 158 millimeter per square meter, and RV SVI is 82 millimeter square meters is a cutoff point for the normalizing RV volumes. This is another study for the progress value of the normalizing RV size after the PVR. So this study is demonstrated that the RV DVI's cutoff point is 155, and also the endosystolic volume is 120. This is a little larger than the previous studies. What summarizes my topics to take home the message is characteristics of the RV contractions are mainly longitudinal contractions, peristalsis movement and below movement, stretching of the free wall over the septum, and no torsion is a basic characteristic of the RV contractions. And stroke volume generated by the inlet and apical segment, more than 80%, circumferential contraction when RV dilated. So RV of the patient would repair the pituitary follow demonstrated to impair the longitudinal and area contractions in global in the inlet and apical segment as well as the free wall, and impair the RV-LV interactions. RV functions in pituitary follow are reduced visible contractions and emptying fractions with directional RVC as increased in RV pressure. The prognostic value for normalization of the RV size after PVRs of pre-PVR RV-EVI is less than 158, and ESPVRs are less than 82. So we have to make sure these prognostic values to normalize RV pressure. So once after exceeded these values, we may consider to the sooner introduction for the interventions. Thank you very much for your attention.